Okay. Welcome, everybody. Thank you for attending today. People can continue to trickle in, but I thought we'd start on time so we can end on time. So excited to introduce Empowering Women Leaders in Academic Emergency Medicine. Such a huge topic, especially as our numbers are increasing. So I'm just going to zip through some of these welcome slides. We will introduce ourselves shortly, but this is who we are. We have no financial disclosures. However, we do want to make it clear that these are our own individual opinions and do not represent SAEM or our institutions. These are objectives, and we'll start with our personal journey. And we kind of figured this is going to be kind of an open, free form format, but I'll introduce myself. I'm Elizabeth Leenellett. I'm a vice chair in the Department of Emergency Medicine at the University of Cincinnati and chief of staff of the local community hospital. And when I finished residency at UC, my personal statement had included the fact that I was going to be a community physician affiliated with an academic health center with zero aspirations of leadership. And I thought I was going to fulfill that aspiration, but the turnaround times for radiology drove me absolutely nuts. And I started, imagine that. I started an ops project that led to an official hot seat, radiologist reading the ED reads instead of it just going into the pile of all the inpatient and outpatient reads. And it resulted in turnaround times that were less than an hour compared to 3+ hours. And I was hooked. I started doing ops. It took me like 8 years to actually start getting into leadership, became assistant medical director. When a new hospital opened on the northern side of town, I became the medical director there. Joined a lot of committees there, ended up being the medical director, and in 2018 had kind of gotten burnt out after doing that for about 8 years and pitched a proposal at that time to become the first vice chair of women's initiatives in my department. Did a lot of work in that space, increasing our faculty, women faculty from like 7 to 30% of our group. Our residency flipped to female predominant. We ended up winning some awards like the AWOM Outstanding Department Award. And my scope grew such that I was doing faculty development, chaired the RPT, the promotions committee at our place, and now do my title is now Faculty Affairs of Inclusive Excellence and Academic Affairs. Now the first part's kind of gone since February, which is sad, but I still do that work. And that's my leadership journey. I'd like to turn it over to Luan.
Sure. Hello, everyone. I'm Lawson. I'm the Senior Associate Dean for Medical Education and Student Affairs at Virginia Commonwealth University. I, too, actually started out as a community physician, and I did that for about 5 or so years. Actually did some things in a clinic setting for a year, really trying to figure out what it was that I really wanted to do. And so ultimately ended up going back to academics, and I told the chair who hired me, I'm a clinical educator. I want nothing to do with administration or research. And then I think probably very similarly began sort of taking up things that I was passionate about, ended up doing some research projects because some residents asked me to do research projects with them. And really sort of, I would describe my career probably as a series of field promotions. I first became the clerkship director after taking on some very small minor leadership roles when clerkship director became ill and they needed someone to start the next day. And so that was sort of my introduction, of which I realized I was woefully unprepared for it. Ultimately went and got my master's degree in adult ed at that point in time and sort of kept volunteering to do things. And so then I sort of had some dean titles, and then ultimately about 4 years ago I actually switched institutions after having been someplace for a really long time. And so that was a great opportunity to sort of really grow and develop in ways that I never would have imagined at that point.
Hi, I'm Dyne. I'm currently the Chief Physician Wellness Officer at Allevue UCLA Medical Center and the Director of Academics for my department in emergency medicine there. And but my leadership journey really is, I don't know, I think I knew as a medical student that I really liked organizing people. And once I found out there was such a thing as a program director, I'm like, that's it. That's what I can do. And then, as an applicant to emergency medicine residency, I said to the program director when he's like, what do you want to do with your life? I'm like, I want to be the program director. And he's like, that's ballsy. I'm like, well, okay. Ultimately, I became the program director. I did that for a long time. I had a lot of leadership opportunities and experiences with CORD. And then I stepped back from my program director role when my kids were in like early elementary school, because I just felt like that was the thing I needed to do at that time. And it was the hardest thing I'd ever done, was decide to pull away from a role that I loved. I loved every second of being program director, but I'd already been doing it for 14 years. And my kids were, I needed to be more with my present with my children. So, so I had that worked out really well. I was able to be with my kids when they needed somebody to drive them, you know, after school and be there at the activities and all that stuff. And then once my youngest got her driver's license, I felt like I had a new leash on life, and actually had an opportunity to come back and become the APD again. I've always been within the UCLA residency program, and got to be the APD again, which is the best job ever when you've already been there and done that, and like it was so much fun. And then I already was the DIO at All of You, which is a small sponsoring institution. Anyway, I've gotten to see a lot in GME leadership, which was a blast, and I love organizing people and middle management and all of that. Then, during COVID, some things started to shift in the world of medicine, as you know, and there was really a need to have more well-being leaders. And so I actually got trained as a certified coach, and then also chief wellness officer. And so I was able to shift from DIO to chief wellness officer for my hospital. And so that's been a really awesome sort of TAM 2.0, journey as I've reinvigorated my career in a totally different space. So got to meet all these awesome people around faculty development, and that's been now. Take it away.
My name is Leigh Patterson. I am the chair of emergency medicine at East Carolina University, and we were program directors in the same time period. I had a little bit different experience. I finished residency and really wasn't sure what I wanted to do. I thought I would like to teach. And I had a very different conversation, I think, with my PD. And I'm grateful for that, because I don't know that I would be where I am at all, except for that first conversation of, hey, I think you could do this. I think you could be a program director. Really, that's kind of crazy. And that is, I think, what kicked off everything for me. But the rest of my career has really been marked by interim appointments taking opportunities as they came up. I also would echo what Pam said. APD is the best job. PD is the best job. I love that.
PD's great.
Did that for a decade as well. But the APD job, if you have it, if you want it, if you try it, it's really, there's lovely things to that role. I came to my current institution as an APD and said, I'm going to do this for 5 years. So the other thing that's marked my leadership journey is I made a plan. I always made a plan, which I just never followed any single one of those plans. So I always made a plan. And my plan was going to be an APD for 5 years, and then I'll go find this PD job. And I got as Luan says, a field promotion as well, and became the PD far earlier than I recommend people to do when I'm coaching people about their career journeys as well. I did that for a decade. Loved it. It probably was the best job. I think there's just such reward in that. And went back to school, got a master's degree while I was doing that, and transitioned somewhere in the end of that to adult education, and really looking at faculty. I thought I'm going to stay in education the rest of my life, and I went to the Office of Faculty Development to work on helping faculty be better teachers, and got that was an interim appointment, same as my first interim appointment as the program director. And then in my time in faculty development, I was dispatched to the Department of Pathology in our institution, and I don't have a background in pathology. I was dispatched there because they did not have a lot of leadership, and I needed a temporary leader, and no intention of becoming a chair at all. I said, this is a great opportunity. I can go back to faculty development and help chairs, and I can help faculty interact with chairs. I'll try this on. And then I got sent to back to my home department to be the interim chair for emergency medicine. And I had that same feeling that this is great. I love the people. I'll go spend some time here, but I'm not doing this job. I don't know that I had the early love for managing people. I don't know that came later in life. But I enjoyed it, and it was, I was still the interim when the pandemic hit, and for me that was a crash course in business. It was almost like getting an accounting degree all of a sudden in the space, and deep immersion into operations and finance, which I did not bring with any background in education. Leader, did not know that. And I think that's honestly where I fell in love with the job and decided I wanted it. But I think you're already beginning to see some of the things we want to talk about today, with lots of different paths to the ultimate space. But ultimately, I decided I wanted the job, and now I've been 6 years into it. So, yeah.
Hi, thanks for being here today, and yeah, please come to the front if you want to talk about, come to the chairs. Yeah, it's a small room, so thanks for being here. My name is Nancy Kwon. Excuse me. I'm currently the Vice Chair of Emergency Medicine at Long Island Jewish Medical Center, which is part of Northwell, which has 18 emergency departments, but most recently merged with New Vance, so we're gonna be about 25, I believe. Yes. So that's the newest thing. I started off my career at Bellevue NYU. I did my residency there, then stayed on as an attending there, graduated in 1999 until 2013. I think at the time, well, in my younger career, I wasn't really sure what I wanted to do. I really thought I was going to be a researcher. I was the co-director of research. I did a lot of abstracts. A lot of those abstracts pretty much did not turn into papers. And I had a chair there, Dr. Goldframe, known as the father of emergency medicine, who was my mentor, who, still is my mentor today, one of my many mentors today. And, he was always very supportive of everything I did, like, oh, that's great, do research. And I think it took me a while. I thought I was like a researcher, but I didn't have any, big grants, just foundation grants. When I graduated from residency, I did get my master's in public administration at NYU, part-time while I was working full-time. And I thought I wanted, at some point to do healthcare administration. But I worked there, I had some small leadership roles, but no big leadership roles. So I got the master's, but I couldn't really apply it, and it was valuable at the time. So I got, I didn't really have any finance classes or anything like that, so I was able to get into that. Then in 2013, I stayed in touch with a lot of my co-residents. The opportunity came up. One of my former co-residents, who's 2 years below me, Dr. Sal Pardo, who I'm still friends with today, reached out to me and said, Long Island Jewish, there's some leadership opportunities, some people who are returning. Would you be interested in coming here as an associate chair? And I was like, I feel comfortable in my shoes at Bellevue. I could probably stay there forever, but I was like, let me just check this out. The leadership opportunities, for whatever reasons, weren't coming to me at NYU Bellevue, but I loved it there. I went to check out LIJ. I went to interview and just had a really good feel from it. It wasn't a city hospital, but it served a lot of underserved patients, and that was kind of one of my areas of concentration or focus or passion. And then I decided to take the job. And later on, we'll talk a little bit about networking and how those relationships really carry through forever. So if I didn't know Sal, I would have never have thought about this job, been tapped for it, or had that opportunity. So I'm thankful to him every day, and we're still friends today. So I started as associate chair without having really any background, and then it was really a really steep learning curve. And then then I could apply the master's, but it had been so many years ago. But it really was trial by fire. I learned so much. I think we developed the program there, and then in 2019, the vice chair there was moving to a different role. Actually, he's my boss still, Sanjay Gupta. So the vice chair opportunity became open in 2019, so I applied for it and was able to become the vice chair. Since I've been doing that, but more opportunities did come, and they did come through networking. So people encouraged me, go meet people who are interested in the same things that you are. So in addition to being the vice chair, through networking and through doing work with other people in passion projects, things that I'm passionate about, which is transitions of care, population health, and health equity. Most recently, I acquired the role as the medical director, the Central Market Medical Director for Health Equity, and that's another area I'm really passionate about. While I've also been able to do my vice chair. And I think more opportunities will come soon in that area, and a lot of that is through building those relationships, doing the work, and having the track record, networking, and that's a little bit of my path to leadership, but also having great sponsors, mentors, and allies. So Jay Gupta is a great friend of mine. It's a great sponsor, great male ally, and I think that's really important. Those are the things that are going to help you, develop your leadership.
We'll go ahead and so we just want to give you a chance to just think or talk amongst yourselves about these questions, about how you would rate the representation of women in leadership roles within your own institution, what you believe are the biggest barriers for women, and if you have personally experienced or observed gender bias in leadership opportunities. And then let you think about it, talk amongst yourselves, and regroup in about a minute and a half.
I'm always interested. Yeah, it was very given where we there were a lot of issues. Just a question. Okay, I don't say I was I really find some there, it's just that was right. So, does anyone want to share a couple of examples that you all discussed? We'll have a couple of volunteers to share. Volunteers to share. Yes, thank you.
Discussing we're at NYU Long Island, we do have a lot of women that are in leadership roles, but they've come into those roles more recently over the past 2, 3, 4 years. And one of the things that we recognize is that we don't have women necessarily as mentors and sponsors for ourselves.
Right. Other items that people want to share?
Well, I think that our institution is great, but I do look at other institutions to see how many full professors are women, and that kind of clues me in on that. And yeah, that's all I was going to add. Okay.
So you all have queued me up for my next slides for a couple of these. So thank you all so much. The good news is what I want people to take away is there's some really positive news in this too. I think sometimes you look at those numbers, you might get discouraged along the way. And I've presented and looked at this data before, and this comes up, they do redo this data every couple of years. But I think there's some really positive things as well as opportunities for us to continue to grow and develop. And so I'm going to go through these pretty quickly so we have more time to discuss. But what you will see, and this looks at representation of women in all of academic medicine, so not necessarily just emergency medicine. But you can see at the beginning of the pathway, there are a lot more women than what they used to be. But as you all have aptly discussed, there are many fewer people as we begin to move into administrative roles, into full professors, into deans. And actually, there are even fewer department chairs than there are deans, which is really interesting to me. Women have moved into the majority of medical school, not only applicants, but graduates. And so this is a pretty significant change compared to when I was a medical student. And there were huge disparities there. If you look at some of the emergency medicine, surgery, and certainly many of the surgical subspecialties, they've increased women residents by 5 or more percentage points. And so you can see emergency medicine is highlighted there, and 42% were the most recent number. So it's not representative of those entry into medical school, but it is definitely making a forward progression. And when we look at women in terms of full-time faculty, they too are increasing in numbers over time as well. And now women actually constitute 51% of our full-time faculty under the age of 50. But you can see in the more senior positions and people who have been doing this longer, there are definitely fewer role models to look towards in that space. But when I look at this less than 30 amount, age less than 30, it is really tremendous there, I think the potential and how much change that we have seen. The great news is too, not only have we increased in the numbers of women, but the women continue to progress in rank over that time, as well as the women faculty who are getting promoted to associate professor and full professor. When we look, though, at emergency medicine in terms of percentage of full-time faculty, full-time professors, but when we look at women in emergency medicine as department chairs, only 15%. So it is definitely on the lower end of the scale in terms when we look at many other departments and what that looks like. And so definitely an opportunity for us to think about leadership, pathways to that, and really this SAEM is a great opportunity to really build those networks if that is of interest to you. And then women are represented, as you might imagine. What we see is generally in academic medicine is that women tend to have more of a preponderance in those teaching kind of roles. So faculty affairs, DEI, raises some questions sort of with recent changes as to what's going to be the impact on women and roles in those spaces. Things like medical education and student affairs are definitely overrepresented compared to research and the clinical affairs component of this. And again, the great news is medical school deans continue, the number of women in those positions continues to rise, but there is still a huge disparity in that space.
All right, so now we're going to talk about what are some of the barriers and challenges to that women have in academic leadership, right? So these are some of the topics that we came up with: implicit bias and gender stereotypes, work-life integration challenges, lack of mentorship and sponsorship, career pause or delay in advancement of rank for various reasons, benevolent bias, and institutional policies and cultures. We're going to really lean into the top two, implicit bias and gender stereotypes, as well as work-life integration. But I just wanted to, because those require, I think we can spend a lot more time there. Have you guys heard of benevolent bias? Are you familiar with that expression? I'm seeing some nods, which is, yeah, it's a term we've all probably experienced, but didn't know that was a term, right? So I'll just read it to you. So it's also known as benevolent prejudice or benevolent sexism. And it's a bias where seemingly positive attitudes, actions, behaviors towards individuals or groups, in this particular context we're talking about women, actually they seem like they're positive, but they actually perpetuate sort of negative stereotypes and decrease autonomy. So an example might be, oh, we're not going to ask this woman to chair this committee because she just had a baby, so she's probably, for whatever reason, probably too busy, that kind of thing. So that certainly happened to me, and I saw it when it was happening, and I'm really glad I had the opportunity to say, hey, I'm going to make my own decisions about how I spend my time, but not everybody has that opportunity because they're not in the room where it's happening or whatever. So ultimately, this perpetuates inequity, right? And while it looks like maybe it's positive to the people in the room who are saying that, it ultimately contributes to the power imbalance that that exists and social inequities. So advance the slides. All right, there we go. So let's talk a little bit about implicit bias. Okay, I'm sure you've heard this term, right? But implicit bias is actually a subconscious association between disparate attributes, okay, that result in inequitable decisions. Okay, so think about that for a second. And this is obviously harmful. But this is really a culturally embedded thing, right? So we can feel bad if you find yourself actually, perpetuating implicit bias or committing that sort of thing, so to speak, then, you don't necessarily have to feel terrible about it, because this is a culturally embedded thing. It's something that just comes with the territory that we live in our country and in our culture. But obviously we know that it can hinder effective communication. It can be very destructive, especially when there's microaggressions associated with that and what's going on inside people's heads and hearts, as they're a victim of that, and can contribute to decreased patient safety. How many times have you been the only female in the room and the patient is talking to the male respiratory therapist who's 10 years older than you and looks more like a doctor, right? This has happened all the time. Patients need to know who the doctor is. It's just a thing, right? But this increases our burnout. And so, yeah, that's implicit bias. Okay, and then gender bias and stereotypes as well. This is, once again, culturally embedded, right? Bias just means a preference for one over the other, right? So we have some cultural stereotypes that females are better at ... and hence get positions, and this was just alluded to, right? Positions related to communion, shall we say, emotionally supportive, potentially less capable. Whereas males, this is our cultural, standard, are better at things related to agency, actions, and they tend to be more. And think about how residents get evaluated, right? They're rational, they're serious, they're strong, right? These are culturally embedded things, so they are certainly can be harmful. But this is the reason I keep hammering on it being culturally embedded is because females are not immune to having these same gender biases, right? So just because you're a woman leader doesn't mean that you aren't potentially perpetuating these same things. Like, a woman should behave in this way. And so if the woman doesn't behave in this way, then there's something wrong with them, right? And that's I've seen this, and it's painful to watch, right? Yeah. Okay, now we'll transition to talking about a little bit about work-life integration. This is a hard thing for everybody, right? It's a hard thing for everybody with who's got lots of things going on in their life. It's even hard for my daughter who has a 10-month-old baby and a 10-hour-a-week job, right? That pays almost nothing. And so that just finding childcare when you can't afford to pay for any of it, that's hard. But we have big jobs and other things in our lives, whether they be big jobs and little kids, or, or big job and aging parents, or, big job and whatever it is, juggling your own personal, whatever it is, we all know there's really an unequal distribution of emotional labor in our departments, right? And the COVID pandemic really highlighted that. The whole work from home while schooling from home is definitely a thing. Okay, so now we're going to do some breakout groups. Okay, so we're going to do a breakout group, one group talking about implicit bias and gender stereotypes, and one group talking about work-life integration challenges. Okay, so we're going to divide the left side of the room, just as the slide says. So you can juggle if you want, you can move around if you want, or we can just stay whatever you want to do. Well, one side over here, we're going to do the work-life juggle, and this side over here, implicit bias.
I'm going to set a timer, so when it goes off, forgive me if I just cut you off mid-sentence.
Yeah, right.
Integration over here, and then we'll try to do like circle over here.
Oh, got it.
So, I think we need to keep in mind that they want to share. This is very much a facilitated group for
all of the things. One question that I was raised earlier from our conversation is in leadership positions with women trying to be assertive, like your student does, whereas like men are perceived as, you know, strong. So how do you overcome that? And how do you shape that? I think that's an interesting conversation piece. How do you say something that is aggression or focus? Because there's emotional ones, motherly, so when you are not, and you're kind of
some of that is
despite you were like an example. I would like that also that member over here and like her male counterpart first like she's not very like is really demonstrated unprofessional behavior, which is not again my question to the group is, what is helping well for you when you talk about that, or do they get that?
Well, I would say our faculty work on amplifying each other's voices, especially in faculty meeting, where, you know, first names are used for the women instead of doctor. And so somebody will say, Dr. So-and-so's point, I want to think is really good and add to just one piece of like data. They really look at her, which is like, I hold it in jail. I was like, and I think that especially a lot of now couples with children, a lot of this social data, not just for medicine, but everywhere shows that in business, that when men I did this now the Dallas early. You did this. Was what it was. So it's 40-60 at the place of all of the corrections. Women do more of the need, the child care, provide to it. You know, it's a lot of this everyone is historical or hopeful. That's okay for it. You know, but that time is we should see it ourselves. So it's just getting to cognizant of it. So in the conference, they kind of to us. I think we know about barriers.
And one thing I like that you said about like amplifying, I haven't necessarily had situations recently, but in the past, I think about the that's president like coming into the space and trying to talk about something that is really that plays out you that is supportive of that. So if he sees an implicit bias, like
doesn't know like is it gonna come up with a list of things that needs to be done?
while it's not priority to them.
In particular way, because like we have this having to take an hour, but I can't. One of our work goes for last and help for this motion. She does not provide her first name. It doesn't matter. We can only just that it's not. Call her very yeah. I mean, it just and hitting. When said her first name and then Dr. last name, in the sentence, like literally right next to also over here. And so I texted him. I was like, hey, they did this. Or he ended up apologizing or but if I called those things, it's that.
Yeah, timing is really important. You know, just like calling people out. One is maybe not aggression because it's a form of aggression. Calling actually loud in the moment. And then the other one is also, especially with emergency medicine, is trying to go into like leadership positions, which a lot of like goodness and leadership type stuff is more of like a 9 to 5 because being able to do that from the shifts that are some bad sometimes all of that and still be able to you're trying to
Know them well, or they're
it's taken me years.
know someone else. So then nobody else is all sorts of things that, you know, like doctor and trying to make up for it. I think it's really hard. Particularly as I schedule this one meeting that I can do.
So you bring up something that like was really the hardest thing I should bring up, which is so how you say something. I find it gets interpreted as so much more like in the shift of I was female meetings like I'm dead, you know, I'm not working. And so like trying to balance that, then this is a global thing, you know?
Yeah.
And that's so good for her. If you can feel safe calling him out or having somebody else.
Ultimately, I'm more, finding an ally, but I think just like explaining to a family that
Can call
that doesn't necessarily
and make it right.
It's hard, you know, there's that feel, the idea, like, my husband does work. I mean, also stay on it, and then we did, so, I started being on a place lab, really glad to go. But you have to be as careful, I feel the pressure to never interact as a resident, you know, the residents are crazy, but I think that it's not for you to take from here. I'm excited about it, but it's just about it. A little softer, I was like, I also think that there's a, I mean, the same. They're all, and now I'm like I feel like men might be more likely to like put strict just shift requests in, so whereas a lot of the younger people
too, I'm on this RCCC residency, and one of the things that I
And then you end up every.
focus on and get frustrated with is especially interns or females who get feedback about having more confidence. And then very,
speaking to like advocating for
even
yourself.
more standoffish, and
I think
need to
social
push
media shows
male
that
residents
in that
out there
as
and
well,
making
you know,
decisions that good.
like that.
Be more
They want the devotion, they want not be. This person, you know, I think she's hard to size working.
Number of evaluations.
Actually take a vacation.
Quality of evaluation.
I think
Give that feedback.
we also
Yes.
those leadership positions right now. Medicine versus domestic.
This resident,
Today, right? So
it's
it's kind of
just a different
those
gender.
areas of like
I so know.
Yeah.
being in a situation
Because in RCCC,
you
we know how to
and that's just what they
convey that to the
you know,
faculty that
having the
they're realizing that they're putting that down on females. It's way more.
I'm very confident.
Yeah, it's a big load of share that AP is very rich at writing out there the formal CCC letter to the resident to interpret basically
Yeah.
what that is. What's happening. It's definitely saying that for sure.
You do, I don't think this is
But I think it requires interpretation and somebody to like scratch the surface and what is actually meant by this, and then hopefully everybody else learn to have some right. That's part of faculty development too about what do we actually mean when we're talking more evaluating residents, and so I think that when we take it the attribution away and focus on the activation.
And it's definitely not and it's usually one or two female residents, and the evaluators are both made females, so females are writing it too. And so it's just very interesting.
That in itself is the
Okay. Wow, I hear some really great discussions going on. I'm so sorry to cut it off.
not enough time.
Great.
Sure. So we wanted to take a few minutes to debrief some of what we did. I will confess in our group, we got a lot to the challenges and not a ton to the strategies. Some of the challenges we were talking about in work-life integration really had to do with balance, lots of priorities, and everything seems to be about time. And are my efforts and energies where I want them to be? I feel a lot of competing demands and a lot of conversation about where our partners fit into this. Perhaps a little bit of but I hope I'm not reading too much into it, but an implied sense of struggle of how do I navigate this? I feel guilty asking even my partner to do more, although I know my partner, I might be doing more, so we're in the room. How about on this side of the room? What did y'all talk about?
I'll just highlight, we largely talked about the culturally embedded aspects of how women often present themselves when they're speaking, and so how that's interpreted by other people. And so, if you come across very direct, then people might take that in a way of being offensive, and that you just need to calm down a little, and and that doesn't feel good, right? So that translates all the way down into resident evaluations, having a lot of attribution of the behaviors I described before, of like they just, can they just be more confident is sometimes a thing that's getting written on evaluations of residents, whereas that kind of thing, those comments don't tend to get written about the male residents. So those are the main topics we
Sure.
discussed.
Anybody have any questions or ideas about strategies? We were lamenting on our side of the room, we didn't quite get all the way to strategies. So questions and the folks had about that, they'd like to, we're happy to open up for discussion even a little bit before we get to the next section.
One of the strategies actually that we discussed was finding, it can be very difficult to advocate for yourself if you're the individual who is, speaks very directly or in a way that isn't necessarily pleasing to the other ears. So finding an ally, hopefully a supportive colleague who can advocate and potentially call other people out on their behavior is a strategy. But you may have to ask for that, right?
Yeah. Although you spent most of your time in California, you could have been in the Southeast with us. Talking about how we're perceived and managing that perception. Other questions?
Oh, I'm Californian, yes I am.
Yes. I'm not coming to Alabama at all. Questions? Other questions or comments? Yes, in the back.
I mean, I think I will cop to the fact that I'm aware of the biases and have used them to my benefit before. So, like, I know that if I say X, Y, Z thing, it'll be taken differently than if our tenured faculty member who's been there 35 years says the same thing in a different forum. That's going to be taken very differently, and they might actually hear him than if I said it. I could maybe help him to go to the meeting to do the thing before. Like, I think knowing, and that goes with like knowing who your allies are, but also knowing how those people are perceived in the different rooms is also probably pretty important. But I do think you can sometimes use the biases the other way to your benefit, like what you want to do.
And to the point of, to both of your points about that as an advocacy, I think that's a great place to recruit some of our senior physicians. None of you have asked, why do we really have fewer female chairs in emergency medicine? We have a number of older males that I think are not necessarily adversaries. They just haven't yet become allies. And that strategy exactly you're talking about, yes, let me help. And it's one of the strategies I think can be very helpful to us of saying, okay, can I grow an ally here who could be empowered to do some other things to speak up? Because it's very interesting. In our shop, we are to a place now where all of the male faculty take leave for new families, for building a family. They are all taking leave for this. When I came to work here, no one took leave. No one took leave. Women took leave. That was it. And it was that was the extent of it. And it's funny how when you hit a critical mass, that conversation shifts. And then for the middle-aged and more senior male physicians in there, suddenly it was, well, maybe I should be able to go do X, Y, or Z too, that for my own health, or maybe I'm supposed to be able to take this vacation, or maybe I need to be at, and then to grow, to see that. So I think that's a long-range strategy, and maybe not where some of you are starting your career are, but it's another strategy to think about. How can I grow that voice, that ally, who is not an adversary, is just too clueless to know. And I say that with all love and affection. I love my husband the same way. But you can grow that. All right. Well, I think we are moving into sort of strategies upright. And I realize I might have stepped off track. So back where we need to be. Okay. Fabulous. All right. So I will trade places with you if you want. And or if you want to just stay.
You can just stay.
Okay, I'll just stay. No problem. Let's talk about some strategies here. There are a host of strategies we need to be using, we could be using to think about advancing careers, advancing women in this space. So I think we can each speak to a number of these things, but we'd love to hear from you. What do you want to know about? What are you curious about? What worries you? What would you like us to address? Mentorship, sponsorship, networking, training and development, finances, how to get flexible work policies. What would you like to talk about today?
Finance.
Yes, ma'am.
I'd love to hear a little bit more about value and belonging.
Yeah, so that's a fantastic, thank you for asking that. The work that I'm as a well-being leader, like the intersection of everything is really about feeling like what we're doing matters and that we belong in our space, right? And so that has a lot to do with who your parent, what's going on between your ears and how you feel about the patient care and the academic work that you're doing. And so that requires so there's a lot of things going on in the world, right? There's things going on in the circumstances that we can't control, but how you think about them is under your control. So I'm putting on my sort of coach hat, but like how you think about what's going on directly affects your feelings about them. This is cognitive theory, behavior. So how you think about the circumstance results in how you feel about them, right? And how you feel about them results in what you do. And so that has everything to do with how you choose to think about them. Now, I'm not saying that you can be gaslit and just be okay about it, right? That's not what I'm saying at all. But be aware that you can think about your thoughts and decide, like, how do I want to think about this thing, right? That somebody said to me, or I didn't get this position, or I didn't, whatever is going on, and or how completely chaotic my Rubik's Cube three-dimensional, Tetris game is of a schedule. Those thoughts are those are in your head, and you can decide how you want to think about them, which results in how you want to feel about them, right? So you can decide, this is all good. I am so capable of this. If anybody can figure this out, I'm going to figure this out. And then when you think, as opposed to feeling like oh my God, I cannot figure this out, right? That I cannot figure this out versus I can figure this out. I am so capable. Feel very differently when if you think thoughts that result in feeling of overwhelm, then you feel overwhelmed, and then it doesn't feel good. If you think thoughts of empowerment, I can do this, then you feel like empowered and capable, and it's a magical thing, right?
Any thoughts on how to flip from the sort of frenetic mind into that capable mind? I think like we're all experienced.
So absolutely. So that's a great question, and it takes some intentionality, right? So it takes some journaling. It takes whatever place you can go to, like, what am I thinking here? Why am I feeling so? Why? Usually you feel overwhelmed, right? You don't think thoughts, then feel overwhelmed. You feel overwhelmed. Oh my God, what am I doing? And why am I feeling so overwhelmed? Okay, and then break it down. And it might require some journaling. I'm a big fan of pencil and pen and paper, or whatever way you want to do that. But just some quiet thinking. Why am I feeling this way? And then kind of you have to back yourself up into the thought that's generating that. And then because you can't change the circumstance. Well, sometimes you can. You can just decide to quit, right? But you can't decide to just not pick your kid up, right? Usually that's not a thing. So it requires some intentionality, and then maybe getting yourself into, there's something called a ladder thought. So like if your initial thought is like, this is horrible, I can't figure this out, and then feeling overwhelmed about it. But what you really want to feel is more neutral, peace, like I can do that. It might be a big stretch to think like this is happening for a great reason. Like I feel really empowered about this. It's a big stretch. So you might go to something called a ladder thought, like as opposed to I can't figure this out, but all the way from that to I totally have this, I've got it, right? Somewhere in the middle of like I'm learning to figure this out, and that's a ladder thought. Capiche? So that's around how do I even get on this subject? We're talking about value. We were talking about like values and knowing your own values and how you can access them, right? So you can feel good about the work that you're doing. And belonging is another whole piece of like how you feel about the people that are in the room and how you show up and sit in the room. Like, do I feel like I belong? Look around. Like when I started, I was literally the second female attending. And the other female attending is a much older Jamaican woman with no kids and never been married. And so we were in very different trajectories, but she was an incredible ally to me and sponsor too. But nonetheless, I just had to decide I belong here. I belong in this space. And that has a lot to do with thoughts and just deciding I'm going to own it.
I wanted to add something about that from belonging from like not from like your internal perspective, but maybe external. And I think you're not gonna feel good at work or want to do things unless you feel valued, unless you feel like you belong. And in terms of the external factors, Pam mentioned like maybe you just leave, and that actually could be a strategy because to feel value and to feel belonging, right? Like you have to have great allyship, great sponsorship, great leadership. There's a saying like you don't quit your job, you quit your boss. And so if you don't have a supportive framework, and that includes having, feeling valued and having belonging, then that's what's gonna happen. Where I work, so my chair is there, Dr. Becker, and he always has made me feel very, that I belong and very valued, and he is very supportive and an ally to females, and is always very cognizant. His wife is emergency medicine as well, as to the barriers and the disparities that women face in the workforce compared to men. So, I think the external force is your team that you work with. If they don't make you feel valued and they don't make you feel like you belong, then it may not be the right place, unfortunately. And, in a group of people, the teams are big, right? There may be, one person who's a leader who doesn't make you feel that way, but there usually are like many other people who can be your sponsor, advocate, mentor. So that means about belonging, there is a lot of overlap with mentorship and sponsorship.
I think we have time for one more question. I'm so sorry. Everything we had such great engagement. Did you have a question, Brett? Oh, okay. Yes.
Can I just make a comment about the leadership training and development? I just wanted to say for this group, if you, SAEM has a really great, and I'm not here advertising them, but I'm advertising for the women in this group. They have a chair development course, the chair development program, and I have no interest in being a chair, but I took it for the knowledge, and I think that knowledge is empowerment. Regardless what you do, I consider myself a researcher. I'm an emergency physician, but I consider myself a researcher. But the chair development course is really excellent. I understand the applications or the opportunity to apply to take it. Doesn't matter where you are in your career. I'm on the older side, I've got lots of gray hair, but I still took it. But you can be younger and know that is an opportunity that's available to you. And I will say in the cohort of 20 that we have this year, there are only 2 women. So we need more women to take that course. And I think, again, you don't have to want to be a chair. I have no desire to be a chair, but it was empowerment to have this knowledge about how a department functions. For me, I took it because I wanted to learn, how do I speak to leaders, or how do I speak to, the leadership of my system to advance what I want to do. And so I think that knowledge is power.
Awesome. On the flip side, there's also e-leads through SAEM, which is very popular, also a great opportunity. AAMC has an early and mid-career leadership seminar, just 3.5 days, but it is a great opportunity to network. And then there's ELAM, which is Executive Leadership in Academic Medicine, which is now going to be open to everybody as of next year. But those are some of the ideas. We'd like to thank you so much for attending. Sorry, the time went so fast. Be available for questions.